Good morning, good afternoon, and good evening. Today we are continuing the same topic that we were talking last session for the Narcoski, dizziness and recurrent falls. So we did have, hmm, you guys have my screen, right? I believe so. All right, so we did talk about a little bit about how to go about the history taking. So now today we are going to talk in general about dizziness and differential diagnose and things that we need to know to pass the NACOSQ with a really good score. So the first step that we are discussing here is clarify what the patient means by dizziness. Remember, in NACOSQ, sometimes the main or the chief complaint is going to be very vague. If it is vague or it is something that you don't even know that what is this, then you need to ask the patient, what do you mean by that? For example, if the patient says that I feel dizzy, it could be anything. It could be vertigo, it could be syncope, it could be presyncope, it could be disequilibrium, or it could be anything, or multifactorial. If you ask him, what do you mean by that? Then he will tell you that how he feels. Then it will help you to find out whether you're dealing with a vertigo or presyncope or this equilibrium, or, for example, as something as simple as arrhythmia or dehydration. Okay, so you need to specify it. If the chief complaint is not clear, ask the patient, can you elaborate on that? What do you mean by this? For example, sometimes you may get a scenario that the patient chief complaint is feeling funny. Like feeling funny is very vague. I don't even know how does the patient feel. Then what is my follow-up question? Uh, Can you elaborate on this? What do you mean by feeling funny exactly? Then he will tell you that, oh, my heart is racing, my heart is beating very fast. Then you know that you're dealing with arrhythmia, right? So if you do not ask this specific question, then it's going to be very vague and you will be all over the place and you cannot take a proper history because you don't know how to structure it, right? So it hardly happens, but remember, dizziness is one of those words that is not very specified or specific. So you need to ask to elaborate. Or what do you mean by that? So most error happens before the exam begins. Why? Because I have no idea what I'm dealing with. So if it is happen to be a physical examination, I have no idea whether it is vertigo, pre-syncope, or disequilibrium, or something else. So I will be all over the place if I have 4 minutes and I'm going to screw that station. So vertigo. So if the patient says, my head is spinning or things are moving around me, so you know that you're dealing with a vertigo, right? It's a false sensation of motion, spinning. Usually the issue here is vestibular. Presyncope. The patient says that nothing is moving around me or anything. I feel that I'm going to faint. So it means the patient is having presyncope. It means you're dealing with something which is most likely cardiovascular or it is orthostatic. Or if the patient says, you know what, when I stand up, I cannot balance when I walk like a drunk person. So that's what the dizziness mean for him. So unsteady gait or balance issue, it means the patient may have or most likely to have neurogenic, sensory, or musculoskeletal issue. Then you're going to focus more on those areas. Not to forget about, like, I don't mean that you totally forget about everything else. You still have to rule it out, but your main issue here or the chief of complaint is pointing toward that this equilibrium, neurology, sensory issue, and musculoskeletal. Now, non-specific, like I'm lightheaded, or it is vague, I can't even explain it. So if it is vague and the patient is not able to explain it, it means it could be medication, it could be anxiety, or it could be a metabolic disorder. So high yield OSCE line. Before I localize the cause, I will clarify whether this is a vertigo, pre-syncope, or gait imbalance because the differential and investigation differ. So this is what you need to verbalize for the examiner. Now, use timing plus trigger to narrow the diagnosis. When we are taking the history, obviously one of the things that we are asking from the patient is the timing and the episode and the triggers. So the episode plus triggers. If the patient says that it takes this vertigo that I have, it takes seconds to minutes. So it means this is either benign paroxysmal positional vertigo or orthostatic. If the patient says that it is episodic, but there is no trigger, it can happen at any time spontaneously and it will last minutes to hours. Now I'm more focusing on Meniere's disease, vestibular migraine, and arrhythmia. If the patient says this is always continuous and it happens and it is always there continuously for hours up to days and it doesn't go away. So if it is that constant, and that severe or that acute, then I'm thinking about vestibular neuritis or stroke. So the pearl, acute continuous vertigo plus inability to walk is a stroke concern until proven otherwise. If it happens that you are dealing with a station that the station says the patient had this issue, and this issue has been there for 2 days or 1 day, or for example, 24 hours, and still the patient is having it, and the patient is unable to walk, it is a stroke until proven otherwise. It means you have to rule out everything until you prove that this is a stroke. Identify red flags, secondary cause until proven otherwise. So what are the red flags in dizziness or vertigo? New focal neurodeficit like diplopia, dysarthria, weakness, severe ataxia. Acute continuous vertigo with inability to walk and aid. So I think this is obvious. Severe headache, neck pain, or sudden onset symptoms. Chest pain, palpitation, exertional presyncope, high-risk context, anticoagulation, trauma, infection, immunocompromise. So these are all the red flags. You cannot pass that station if you do not mention these red flag. I mean, if you do not ask it or rule it out. So these are very important. In each station, you cannot forget about red flags. You have to cover it. Recurrent falls, red flags. Syncope, near syncope, or unexplained recurrent falls, head injury, anticoagulant, persistent vomiting or headache, and also unable to weight bear or suspect fracture, neurological finding after a fall. Focused history, 2 to 3 minutes. I'm going to skip this one because we have already talked about it. So for the history, we have a structure. If you're dealing with dizziness or recurrent fall, just apply the mnemonic that is Dr. Jala Falls. If it happens that you did not attend the last session, I encourage you guys to watch that. I think it is under geriatric, and you will be able to see that how you're going to approach or structure the history taking from somebody who has dizziness or recurrent fall. So high scoring phrasing. Because pre-syncope is possible, I will ask about palpitation, exertion symptoms, review medication, and check orthostatic vitals plus ACG. Very important to mention this. Why? Because these are ruling out the red flags. Not ask a physical examination what the examiner expect you. Say what you're checking as you do it. It means you need to verbalize things that you're doing. You don't have to turn around and have a proper eye contact because you're busy doing the physical examination. You need to have all your focus on that physical examination, but it does not mean that you totally forget about the examiner, that he has existed in the room. So whatever you do, you keep on doing it, but verbalize it loudly so that he knows that not only you know how to do it, and you verbalize it to me and make sure that I do understand that you know it. So sometimes we do the thing and it always happens. Trust me, when you start doing the physical examination, you're so focused, you're so into doing those physical examination that you completely forget about the examiner. And the examiner is not a mind reader. So he needs or expect you to verbalize every single thing that you are doing on the patient. For example, I'm checking for vitals. Now I'm checking for the pulse. Pulse feels both sides are symmetrical, strong, or weak, whatever it is. So you need to do it and verbalize it at the same time. Orthostatic blood pressure, heart rate when safe, glucose, ECG for pre-syncope and syncope if possible. Neuro and gait, cranial nerve, strength, sensation, coordination plus gait, tandem if safe. The coordination plus gait is the tandem. So it is like this. You ask the patient to walk like this. I will show you when we are going to do the physical examination, checking for the neurology and gait or balance. Romberg's test is you ask the patient to stand straight and close his eyes. And the patient, if has any issue, then the patient is gonna fall down to either side. And vestibular or ENT, nystagmosis, direction suppression, head impulse, if trained, Dix Hallpike maneuver when episodic triggers triggered a vertigo. So for the benign paroxysmal positional, the diagnosis, well, with Dix Hallpike maneuver. We will talk about it in details. So investigation or the test based on the phenotype plus red flags. So it means that you do not bombard the patient with investigation. You only customize it based on the condition that the patient has. So avoid low value testing and explain it why. For example, pre-syncope or syncope suspected ECG. Orthostatic vitals, CBC, electrolyte, pregnancy test if indicated, risk stratify at med monitor if high risk. Now, if it is peripheral, like benign possession, paroxysmal possession vertigo, then you don't have to do any ECG or you don't have to do any imaging. You do not need to do any further or intense investigation because this is based on history plus clinical uh, uh, diagnose, right? So it doesn't require a lot of investigation. So do not order unnecessary investigation because you're charging the government for no reason. So diagnosis clinical history plus Dex Hallpike maneuver. For the NACOS key, you need to know how to do it. I have never seen it, and I have never heard anyone that who has told me that yes, we had the vertigo and I did the Dix-Hallpike maneuver. I haven't, but it doesn't mean that it's not going to be in the licensing exam. It might. So if this is benign paroxysmal positional vertigo, you need to do the Dix Hallpike maneuver. And I will show you how to, and we will do it in the class when we start the physical examination. And obviously, history. No routine imaging when typical and neuro exam normal. Treat with Epley maneuver. So the treatment is Epley maneuver. Again, so no medication for this. When to image or urgent consultation if the patient has red flags, basically. Focal neuroscience, severe truncal ataxia, acute continuous vertigo with central feature, new severe headache, neck pain, head trauma, anticoagulation, concern for the TIA or stroke. Then benign paroxysmal positional vertigo. So 4 things that we need to know: pattern, diagnose, treatment, and OSCE pitfalls. So what is the pattern? The pattern is that it lasts seconds. It lasts seconds of vertigo with head movement. When the patient moves the head from right to left, left to right, right to left, or if the patient change his position in the bed from right to left and left to right, the patient experience spinning or vertigo, and it goes away. So the patient has no focal neuro deficit, and the patient has nystagmosis. And this nystagmosis will be positive while you're performing the Dix-Hallpike maneuver. When you're changing the patient's head from one side to other side, and the nystagmosis positive. It means the test is positive, and then you need to do Epley maneuver, and the patient will feel better. So the diagnosis Dix-Hallpike maneuver when appropriate, classic story plus normal neuro exam. Treatment, Epley maneuver, first line. Avoid chronic vestibular suppressant, the OSCE pitfall. Avoid routine imaging. So if you know that I have the benign paroxysmal position vertigo, then ordering extra and unnecessary imaging and investigation is only causing you a lot of score. So do not do that. Now, acute continuous vertigo, neuritis versus Lebrinitis versus stroke. So if it is acute continuous vertigo and the patient cannot walk, this is a stroke until proven otherwise. If it is hours to minutes to hours, then it's most likely either neuritis, vestibular neuritis, or Lebrinitis. But if it lasts more than 1 day, it is more likely to be stroke in terms of timing. Okay. Now, vestibular neuritis, as I mentioned before, it is hours to days and it's continuously there for hours to days. Now, the thing that differentiates vestibular neuritis from Lebrinitis is vestibular start with V and neuritis start with N. Nausea, vomiting. Remember this way. Vestibular neuritis, V for vomiting, neuritis, N for nausea. Usually, if the patient has vertigo continuously for hours to a day, and the patient has nausea, vomiting, but no hearing loss, but nausea, vomiting is very concerning for the patient on the top of the vertigo. That is vestibular neuritis. If the patient has the same sign and symptom, but no nausea, vomiting, and the patient has hearing loss with tinnitus, that's Lebrinitis. Okay, that's the differential diagnosis. This is how you remember it. So remember, vestibular neuritis, VN, vomiting, nausea for vestibular neuritis. Lebrinitis does not have it. Lebrinitis has loss. Lebrinitis starts with loss. So it has hearing loss and tinnitus. But vestibular neuritis has vomiting, nausea, but no hearing loss. Okay? Now, posterior stroke, central neuroscience, or severe truncal ataxia cannot walk. For this one, I don't think you would have any problem because the patient will give you all the neurological symptoms. Direction changing nystagmosis, diplopia, dysarthria, high vascular risk. So for the vestibular neuritis, supportive treatment, short course of antiemetic if needed, plus early mobilization vestibular rehab. But for Lebrinitis, treat underlying cause. Whatever is the cause, treat that. Whether it is virus, whatever it is, usually the virus is not being treated. So if it is bacteria or anything that triggered it, but in Lebrinitis, usually the cause is the virus, treat the underlying cause. ENT follow-up when persistent or severe. Urgent stroke pathway and imaging prelocal cortical. Meniere's disease. So, episodic vertigo plus auditory symptoms. Remember, for this one, you might get a question, not only one question, probably you get one or two questions because this is very commonly tested in MCQ1. So, but it is important to know it as a differential for the Nakoski if you have a dizziness. So episodic vertigo plus auditory symptom, the clinical pattern is recurrent episodes of dizziness, which last minutes to hours, and it's fluctuating hearing loss. It means the hearing is sometimes it's good, sometimes it's bad. Good, bad, good, bad. So if you have vertigo with a good and bad hearing, and the vertigo is episodic, Like it's not all the ways, always. It happens, then it stops, then it happens, then it stops, and the hearing loss is getting better and worse, better and worse. Then think about Meniere's disease. One thing. The other thing that points toward the Meniere's disease is the patient usually have a history, family history, which I forgot to put it here. They usually have a family history of the same problem, Meniere's disease, and tinnitus and oral fullness. These two things are also very important to remember. Tinnitus and oral fullness. Management, the triggers control. Salt, these are going to be in the licensing exam. What is the, it might ask you what is the best diagnose, which if you have a young, this is another thing I forgot, young patient, family history of the same condition, and the patient has episodic vertigo with the fluctuation hearing loss, and the patient has tinnitus and oral fullness, then what is the best diagnose? Meniere's disease. Or they might ask you, what is the treatment? The treatment is trigger control, salt, alcohol, caffeine restriction. Vestibular suppressant short term only for severe. So we don't usually use it unless it is severe. Usually restriction of salt, alcohol, and caffeine will help. ENT follow-up, audiology when indicated. Differentiate from vestibular migraine. So basically, migraine will have migraine history feature are dominated. The patient will have also some sort of headache, which is not present in Meniere's. Vestibular migraine, again, same characteristics, same clinical feature, but the patient will have migraine, okay, during the attack. So I'm not going to discuss this because migraine is so easy. Everybody knows this: photophobia, phonophobia, motion sensitivity, aura, vertigo episodes, minutes to hours. Lifestyle, obviously we know the sleep, hydration, caffeine, stress, acute migraine therapy when appropriate, preventive, and frequent disabling, patient specific. So the tips is, do these episodes occur with a headache or light sounds sensitivity? Why? Because we want to differentiate if the patient has vestibular migraine. If the patient has no issue with the patient has no headache, no sensitivity to light, no photophobia, no phonophobia, then it is not vestibular migraine. It could be anything else other than that. Probably Meniere's. So pre-syncope or orthostatic hypotension, very common and very testable in the licensing exam. This is very common, not only in license in NACOSC licensing exam, in MCQ1 as well, when it comes to geriatric or when it comes to dizziness and frequent fall. Typical story: dizziness, pre-syncope on standing improves sitting or lying. So when the patient stands up, the patient feels dizzy, but when the patient sits down, the patient gets better. Contributor could be dehydration, it could be blood loss, autonomic dysfunction, and medication triggers could be diuretic, vasodilator, and sedative. Management: treat the cause, fluid, stop offending meds, manage bleeding. Non-pharmacologic, slow position change. Like when the patient, I don't know if you guys remember, Dr. Said Mursal, I think she was the one who was doing the consultation. She did really good job. And one of the most important point in terms of consultation when you are consulting the patient, counseling the patient, you need to let them know how he can change the position, because it is position changing dependent. Like when it happens when you change position. So how we can change position in a very safe way, slowly, and instead of standing abruptly or suddenly, you can just hold, for example, from the wall or from the bed or from the table or from the chair, something that can make you steady, and then slowly stand rather than abruptly. And hydration, compressive stocking, consider pharmacotherapy in persistent symptomatic cases, supervised. It hardly happens to provide them with medication because usually the cause is either the dehydration or medication. When you change the medication and treat the dehydration, they usually get better. And the compression, if they're very old and they have issues with the elasticity of the vessels, then in that case, it will help. OSCE line, I will measure orthostatic blood pressure, heart rate, and review medication that contribute. Usually, they are the culprit, and when you remove them or take care of them, the patient will feel better. Syncope, cardiac causes. What you must not miss. High risk feature, exertional syncope, chest pain, palpitation. Non-structural heart disease, abnormal ECG, family history of sudden death. So if you have these, it means this is cardiology issue. Minimum workup, ECG, vitals, including the orthostatic when safe, targeted labs, if indicated, CBC, electrolyte, troponin, uh, per local protocol. Risk tools, Canadian context. The Canadian Syncope Risk Score helps predict 30-day serious outcome after emergency department assessment and support disposition decision. OSCE disposition phrase, if high risk features are abnormal, ECG are present, if high-risk feature or abnormal ECG are present, I will arrange urgent monitoring, admission, and cardiology evaluation. I think this is very straightforward. It doesn't need extra explanation. Recurrent fall treat as a syndrome, usually multifactorial. So multifactorial, it could be medication. What kind of medication causes dizziness? Sedative. So if you're taking history, you cannot forget about medication. Red flags. So if you have a structure, you will not miss it because that structure that I made for you guys in the morning that says Dr. Jala Falls, it covers almost everything. But if you forget that mnemonic, then you are in trouble. So that's why I make mnemonic for each condition. That way, it make it very easy for you guys to cover everything and you will be on the safe side. So medication you cannot forget when you not only about dizziness, if you're dealing with any geriatric, with any condition, especially if it is geriatric, please do not forget the medication. And what type of medication? If again, especially if they are geriatric, sedative, anticholinergic, opioid, and antihypertensive medication. Orthostatic hypotension, dehydration, gait balance, strain, chair rise, gait speed, tandem, vision, hearing, plus footwear, feet, environment, lighting, rugs, stairs, bathroom, safety. We have already discussed it in the last lecture and last session. Always document. So we need to document. We have a station that's called documentation and prescription. But again, it hardly happens to get this, very time consuming, but you never know. But if you're doing documentation, number of falls in the last 12 months, injuries, fears of falling, baseline mobility plus assistive device. Falls prevention plan. This is very high yield intervention. Multifactorial intervention prevent more falls. Core action most testable in the licensing exam. Describe high-risk myths, which we just did discuss it, right? Strength plus balance exercise, the PT, Tai Chi type of programs. And home safety, lighting, stairs, handrails, remove hazards. We all discussed it, that these are the important points that we need to discuss before we discharge the patient. If the patient does not have any home safety, we need to put the patient in nursing home, or we make sure that the patient is somewhere where the environment is safe, or there is somebody who is looking after that patient. Vision and footwear optimization. Medical contributors to treat orthostatic hypotension, dehydration, we need to treat it. If it is neuropathy, B12, diabetes, Parkinsonism, we need to treat it. If it is arthritis, it is pain-limited mobility, we need to treat it. Osteoporosis, risk review as appropriate. So the OSCE wrap up, because falls are multifactorial. So this is something that gives you a lot of mark. So since falls are multifactorial, my plan is mid-review, exercise, home safety, vision plus feed, vision and feed, plus treat the orthostatic causes and PT, OT referral and follow-up. So this is the whole wrap-up of my decision for the patient. Now, differential or diagnose for paroxysmal, benign paroxysmal positional vertigo. Dizziness is vertigo. Timing is usually brief, and it usually be triggered by what? By movement, changing of position, head or the whole body. And the key clues: rolling in bed. Usually they give you like, when I'm rolling on right side or left side, this is what happens. No neural deficit or looking up. So vestibular neuritis is usually also vertigo, acute continuous. It is acute, but it's continuous. The patient has no hearing loss. And in directional nystagmosis. This is the difference between vestibular neuritis and benign paroxysmal positional vertigo. And the patient has what? Vestibular neuritis, vomiting and nausea. Supportive treatment plus vestibular rehab. Meniere's vertigo, episodic, spontaneous. The patient has hearing loss, tinnitus, aural fullness, and ENT audiology pathway. Vestibular migraine, we know the patient will have all the signs and symptoms of vestibular neuritis plus migraine and symptoms of the symptoms of the migraine, like photophobia, phonophobia, and so on and so forth. Stroke, vertigo, disequilibrium, acute continuous, severe ataxia, focal neuroscience, stroke pathway. Orthostatic, we know it happens with the standing or abruptly standing. Meds, volume loss, autonomic, orthostatics, meds plus review. Arrhythmia will be pre-syncope and syncope. It will happen suddenly. The patient will have palpitation, exertional, abnormal ECG plus monitoring. Neuropathy, Parkinsonism, disequilibrium. It will be chronic, sensory and shuffling gait and freezing gait. And the patient will, the treatment is, or the best next step is treat cause plus PT plus 8. Mechanical environment, non-brief, situational, trip hazards, poor lighting, footwear, home safety, and exercise. We have already discussed this. 60-second Nagoski summary script. So say it like this. Clarify symptoms, vertigo versus pre-syncope versus imbalance. So screen red flags, this vitals plus glucose orthostatic when safe, ECG when pre-syncope and syncope is possible, neuro exam plus gait, vestibular exam, Dex Hallpike if benign paroxysmal positional vertigo. All plans, mid review, exercise, the PT, home safety, vision, and feed. Remember, danger first, then phenotype, then targeted bedside test, then prevention plan. Thank you very much.